to discuss some points on thin fat Indians, sarcopenia, a typical Asian Indian phenotype. I just like to place before you that there is a complex interplay between the genetic and environmental factors contributing to increased visceral adiposity, and that is determined by the genetic foundation, the culture, the exercise habit, the diet, the lifestyle, and the evolutionary history, and all determines the nature of the subcutaneous fat and visceral fat. You just listen to my previous speaker on the fat. This is a very important and very commonly seen picture. This is Eukin, very famous diabetologist from Germany, and this is our beloved Yagnik from Pune. Both of them had 22.3 BMI, but the body fat in Eukin, German, is 9.1%, and for Yagnik is 21.2. So I just like to place before you that Indian are considered as obese lean persons because of their high intra-abdominal fat. As the risk of sarcopenia increases with type 2 diabetes patient, older adults with sarcopenia may have also an increased risk of developing type 2. In Korea, individuals with the lowest skeletal muscle mass relative to body weight quartiles had a twofold greater risk of developing type 2 compared with individuals in the highest title. One data has shown association of modules of co-expressed lipodystrophy gene with diabetes-related intermediate phenotype traits that suggest their role in pathophysiology of diabetes. So lipodystrophy and diabetes are interrelated. There is genetic and environmental factors contributing to visceral adiposity in Asian population also. What is sarcopenia? Age-related decline in muscle mass and function. From 35 onwards, everyone is having sarcopenia, but diabetes are more responsible for both a cause and consequence of type 2. Type 2 is manifested by insulin resistance, increased advanced glycation end products, increased pro-inflammatory phenotype, and oxidative stress, and may lead to micro and macrovascular complications. All these changes can interfere with normal cellular functioning and cause cell death, leading to losses in skeletal muscle mass, strength and function, and finally the development of sarcopenia. Again, low muscle mass and function due to sarcopenia can lead to poorer glucose disposal and decreased metabolic rate and physical activity, all of which may play roles. Older adults with sarcopenia at increased risk for developing type 2 diabetes. What is the incidence? 10 to 40% in healthy men and women aged 60, whether diabetic, they are all non-diabetic. Older type 2, increased risk of sarcopenia. In Japanese, Chinese adult, older people, type 2, 15% had sarcopenia. In type 2, threefold higher odds of having low skeletal mass. Trait, which is a marker for sarcopenia, 8 years later than in men, but not in women. And this is a very important picture which shows that how it occurs. With aging and obesity, there is low metabolic rate, low physical activity, low sexual hormones, and this leads to visceral and ectopic fat accumulation, which all leads to insulin resistance. So there is adipocyte hypertrophy, hyperplasia, accumulation of immune system, and there is also mitochondrial dysfunction, increased oxidative stress, and anabolic action of IGF-1 on the muscle. All these lead to a sarcopenic obesity. And there are the molecule cellular different aspects. The sedentary behavior, the decrease in motor units number, immunosenescence, immune alteration, I will come later on, increased inflammation, mitochondrial dysfunction, and malnutrition. And as a chronic disease, they all lead to this sarcopenia. And the vicious cycle goes on. The decreased physical activity, inflammation and oxidative stress, diminished myostatin, which are concerned with the muscle activity, insulin resistance or hormonal change, that all lead to either sarcopenia and obesity or both together. And obesity can lead to sarcopenia, and sarcopenia can lead to obesity also. And finally, resulting in manifestations of dyslipidemia, type 2 diabetes, cardiovascular disease, hypertension, and frailty. Sarcopenia can lead to clinical and functional complications. What are they? Impaired ability to perform daily activities. So there may be mobility disorders, poor quality of life, malnutrition, increased risk of falls, and finally lead to increased risk of mortality. These are the different complications: reduced pulmonary reserve, impaired pulmonary vasodilatation, vascular recruitment, ventilation, perfusion, mismatch. There are chances of developing of the peripheral vascular dysfunction, anemia, iron deficiency, obesity, poor nutritional status, impaired autonomic regulation. There are cardiac problems like systolic dysfunction, functional mitral regurgitation, ventricular diastolic dysfunction, left atrial dysfunction, chronotropic incompetence, and ventricular arterial uncoupling. There has been different structural abnormality, autonomic changes, and finally skeletal muscle dysfunction. There is an interplay between the diabetes and sarcopenia mechanism, as because the skeletal muscle accounts for 80% of the glucose clearance during euglycemic and hyperinsulinic condition. Deficit in muscle mass may lead to the metabolic abnormality because glucose absorption during hyperglycemia and disposal during hypoglycemia is much less. Type 2 diabetes in turn may lead to vicious pathological sarco, and that is because of insulin resistance, inflammation, oxidative stress, advanced glycation end products, and vascular complication. The effect of blood glucose regulation on sarcopenia parameters in obese and diabetic patients was studied by Ojutik et al. And they have shown in a patient with mean duration of diabetes for more than 16.2 years, in the better control group blood sugar, sarcopenia parameters such as gait speed, muscle mass, and hand grip strength improved. However, only the change in the muscle mass was found to be statistically significant, but no significant change in the parameters of sarcopenia in the patient group with higher A1C more than 8. That means better blood sugar control found between the muscle mass and A1C. This study demonstrated that lower A1C report has got positive effects on muscle mass even in diabetic and sarcopenic obesity. Insulin resistance may lead to impaired vasodilatation of the vessel, increased oxidative stress, chronic inflammation, and all leading to higher concentration of NEFA, vasoconstrictor, cellular adhesion molecules, and other mediators. While sarcopenia negatively affects insulin sensitivity and increases insulin resistance, this resistance aggravates sarcopenia by increasing the loss of skeletal muscle. The different factors I will discuss one by one. Insulin resistance MRO study, men more than 65 years without type 2, but in the high quartile for insulin resistance, at twofold higher odds of losing more than 5% of total lean mass over the approximately 5 years. Next study, gait speed was seen to be decreased across increased quartiles of insulin resistance in non-diabetics, older but not in women. In one study, 968 elderly Italian insulin resistance was negatively associated with hand grip strength and normalized to BMI in women but not in men. These observations reveal that insulin resistance is a predictor of poor muscle health irrespective of diabetic status. Glycemic condition in older Korean more than 65, poor glycemic control was correlated with poor lower limb muscle quality and performance. Baltimore longitudinal study of aging, knee extensor strength was seen to be lower across increasing quartiles of A1C. That means more and more A1C higher, poor and poorer knee extension strength. Patient cannot walk properly, cannot stand up from the floor. Probably the loss of muscle strength and mass in individuals with poor glycemic control likely occurs due to increased protein degradation. Inflammation, low-grade chronic inflammation is present in type 2, and that also acts on the muscle homeostasis. The waist circumference, which indicates the interleukin 6 and TNF alpha activity, is negatively associated with muscle strength, quality, and performance. But it is not clear whether these negative associations are driven in part by increased inflammation. But interleukin 6 is also produced by myocytes during exercise, and transient increase in IL-6 help in nutrient mobilization and muscle hypertrophy. Opposite to this, IL-6 causes muscle atrophy localized to the tibial anterior in rats regardless of systemic inflammation. Framingham heart study demonstrated that IL-6 predicted 2-year lean mass loss in women. So the issue about the IL-6 is doubtful whether it is damaging or improving. Park et al. Documented that older adults with type 2 had greater losses in leg muscle mass and strength over 3 years compared with non-diabetic control, and these associations were related to interleukin-6 and TNF-alpha values. Other than negative association with muscle mass, inflammatory markers are also negatively associated with muscle strength. Visser et al. Reported that hand grip strength was 1.1 and 2.4 kg lower with increase of interleukin-6. TNF-alpha also is negatively associated with grip strength, and other studies has also shown relation of the CRP and other inflammatory markers to be related to sarcopenia. Patients with type 2 diabetes and sarcopenia had higher mortality, irrespective of age, sex, and diabetes. And the effects of sarcopenia on overall survival was larger in those with lower adapted diabetes complication severity index in male patients, younger diabetics, female, and older with diabetes. Obesity, multi-parametric MRI reveals significantly elevated liver fat, hyperinflammation in participants with type 2 despite normal liver biochemistry, and this corroborates with the significantly lower measures of skeletal muscle and higher fibers. So this indicates sarcopenia is associated with also non-alcoholic fatty liver disease. Oxidative stress is another important factor associated with type 2 diabetes, and both in development of sarcopenia, and study has shown poor lower limb muscle quality and physical performance with increased oxidative stress. In 107 pre and post-menopausal women, increased oxidative state was associated with skeletal muscle index adjusted for height, and oxidative also impairs satellite cell differentiation, damaged DNA, so muscle production is hampered. Mitochondrial dysfunction is another factor. Older individuals appear to have up to 50% lower oxidative capacity because of mitochondrial dysfunction, and you know that higher advanced glycation end products means more and more chances of the muscle loss, and this is proved in different study also. Advanced glycation end product associated muscle weakness arises through increased protein cross-linking within the muscle. This interferes with contractility and also increasing inflammation and oxidative stress. And studies with skin autofluorescence has proved higher advanced glycation index in end products are associated with lower muscle mass. Microvascular complication, very important, is neuropathy. They impair muscle contractility, resulting in poor muscle strength and muscle. And neuropathy had lower knee extension strength relative to body weight, and has shown that poor peripheral nerve function was independently associated with poor physical performance outcome. Type 2 diabetes also had poorer physical performance when compared with controls in patients who had neuropathy. Interestingly, retinopathy, probably as a part of the microvascular involvement, and which also indicates microangiopathy in muscle, are also associated in different studies. Presence of advanced retinopathy with presence of sarcopenia also. Diabetic nephropathy, type 2 diabetes, diabetic nephropathy had 2.5-fold higher incidence of sarcopenia. Sarcopenia increases with severity of CKD. In CKD patient not on dialysis, GFR was positively associated with the lean mass. So lower GFR, lower lean mass, lower appendicular skeletal muscle, and appendicular lean mass also. Sarcopenia and obesity showed a synergistic impact on the increased risk of albuminuria also. And the pathophysiology behind the relation of sarcopenia and CKD are increased inflammation, protein loss, reduced vitamin D, mitochondrial dysfunction, and metabolic acidosis arising from CKD. Macrovascular, it is probable that hypertension can damage myocytes, but this loss of muscle also can lead to hypertension. And study in cases of DB rights has shown that reduced systolic and diastolic blood pressure and mean arterial pressure regardless of adiposity and body weight. The positive effects of blood pressure were thought to be due to improved renal function resulting from metabolic improvement. Peripheral artery disease associated with lower hip extension and knee flexion strength in older age had slower gait speed and reduced blood flow from peripheral artery disease, leads to ischemia and muscle loss. Out of the hormonal changes, reduced androgen and estrogen decreases muscle mass and strength, and decreased IGF-1 is associated with muscle growth, impairment, and low muscle mass in healthy people in patients with type 2. Intramuscular adiposity and type 2, these are details I'm not going. The IMAT consists of non-contractile tissue, and the fat infiltration into the skeletal muscle affects the elastic property of the skeletal muscle. So even the muscle bulk is there, it do not work properly. Relation with the cardiovascular outcome, sarcopenic obesity is associated with increased cardiovascular disease. In the British Regional Heart Study, sarcopenic obesity showed a significantly higher risk of mortality compared to non-sarcopenic obese person, non-obese person with cardiovascular outcome. And a meta-analysis has shown 24% increase in risk of all-cause mortality compared to patients in sarcopenia out of cardiovascular disease. Beta cell function, sarcopenia was an independent risk factor contributing to the development of diabetes in an elderly person. An elderly onset diabetic patient show more preserved beta cell function, but nevertheless were insulin resistant and development of the sarcopenia. Now I am going to the commonly used glucose lowering medication, how they are helping or damaging. Out of the commonly used glucose lowering medicine, some improve muscle bulk and some damage. Metformin stimulates AMPK activity, which inhibits the mechanistic type of rapamycin or mTOR activity, and which is a key growth factor of muscle. Assists in mobilization of M2 macrophages, which could have anti-inflammatory properties in skeletal muscle. Profound effects on skeletal muscle through activation of AMPK, like improvements in structural integrity, oxidative metabolism, resiliency to muscle damage, and macrophage polarization. It enhances mitochondrial respiration in skeletal muscle of AMPK deficient mice after just 2 weeks of treatment. Get speed is improved by metformin. This is most likely due to administration of metformin may improve insulin resistance and the suppression of the advanced glycation products, and also suppression of inflammation. So for all probabilities, metformin is improving the sarcopenia. Pioglitazone improves energy metabolism of the muscle cells and reduces the intramyocellular lipid content, improve fatty acid metabolism in polycystic ovary, increases mitochondrial biogenesis and ribosomal protein biogenesis in skeletal muscle, improves the effect of resistance training on muscle. MRO study revealed that men with diabetes treated metformin alone and metformin plus has already been done for 7 years, followed 3.5 years. Follow-up had an attenuated loss of total lean mass and acute lean mass, and this shows that pioglitazone and metformin in sensitizers are better for sarcopenia. DPP-4 inhibitor results are consistent with the hypothesis that DPP-4 inhibitor use might have a positive effect on the loss of muscle mass and its function. GLP-1 analog liraglutide induces loss of fat and increased skeletal muscle. However, one study reported a significant fat mass loss and also skeletal muscle. SGLT inhibitor, different studies have shown in the long term, they not only lower the intramuscular fat, but they may lower the muscle mass also. But one study has shown that it improved the hand grip strength in both women and men treated with SGLT for 10 years. Sulfonylurea can cause muscle atrophy in a very small proportion of cases, and this skeletal muscle by reducing the protein content in the muscle in mice as follows: lipaglinide, more than glibenclamide, more than glimepiride, more than tolbutamide, and nataglibenide. So out of the sulfonylurea, glimepiride is safer, and in vitro data indicate that sulfonylurea, particularly glibenclamide glinides, should be used with extreme caution in presence of the sarcopenia. Insulin, there is an alteration in the response of muscle anabolism to the insulin. Insulin possesses anabolic effect on the muscle and protein metabolism, improves muscle bulk, and is a growth factor for the muscle. Insulin increases collagen synthesis. And Timmerman showed that endothelial dependent vasodilatation and the consequent increase in nutritive flow and the mammalian target of mTOR activity are all improved. So for all probability, insulin will help in sarcopenia. Is there any specific therapy? The answer is no. Transdermal testosterone gel has been tried. In some cases, produces virilizing activity. For that reason, selective androgen receptor modulators that only bind with androgen receptors with the skeletal muscle has a lower virilizing effect are more acceptable. Many treatments under clinical trials are recommended, like activin type 2B receptor antagonist and myostatin blockers. Actually, myostatin negatively regulates myogenesis. The RAS blockers, by suppressing the NF-kappa beta activation and by inhibiting the inflammatory markers, they also improve the sarcopenic state, and by improving the cardiac output and hemodynamic parameters and endothelial function, they also improve muscle blood supply and metabolism. Physical activity always better, and it shows that greatest reduction is A1C are observed with individuals undertaking combined resistance and aerobic exercise. So this is recommended. Resistance training in the most effective strategy, and combined resistance and aerobic training led to 21% improvement in physical performance. And this is the most predominant, highly acceptable resistance and combined aerobic training. Protein intake, it should be higher, 1.2 to 1.6 kg. And they have shown, the health ABC study has shown improvement in cases of muscle bulk. Animal protein is better than plant protein in terms of sarcopenia requirement. Protein-rich diet, 1.3 gram per day achieved through lean red meat was safe and effective. Long-term excess leucine may help for prevention of treatment of sarcopenia. Vitamin D supplementation is helpful when vitamin D level
Dr.
is
Samar, sorry to interrupt,
yes,
but we are running out of time.
I am just concluding.
Yeah.
Omega-3 fatty acid is also of some help. In the conclusion, I'd like to place that aging and diabetes are both risk factors for functional impairment from sarcopenia. Between type 2 and sarcopenia, as one condition may increase the risk of developing the other. Several factors like insulin resistance, inflammation, advanced glycation end products, increased oxidative stress, vascular complications, all are present in diabetes. They act on the sarcopenia. Exercise remains the primary and most effective treatment, particularly combined with aerobic and anaerobic. Resistance exercise are much better. We need further research to better understand, treat and prevent comorbid sarcopenia and type 2 diabetes. I am ready to declare that the sarcopenia object is very much neglected in cases of diabetes that are the causes of increased mortality and morbidity. We also need early detection of sarcopenia and frailty in older adults with diabetes as a routine clinical practice to facilitate early multimodal infection. So I thank all the listeners for listening to this. And this is coming, this chapter is coming in my upcoming book, which will be released in June, available in Amazon, on neurodiabetes. Thank you for your patient hearing, and thank you for giving me the chance. Thank you again.